Welcome to the Palliative Symptom Management Pre-Printed Orders 6-month revision presentation. My name is Vicki Kennedy. I'm a clinical nurse specialist with the Palliative Care and End-of-Life Services team. So our objectives today is to present the revised Palliative Symptom Management Pre-Printed Orders numbers 81340 and 829571. I'll identify the revisions made at the 6-month post-implementation mark and briefly describe some next steps. So in the implementation of the standardized Palliative Management pre-printed orders in August of 2019, as the PPOs were being used at the point of care, we started to receive feedback, some directly and some indirectly, both positive and constructive feedback. So we took this on board and followed the suggestion to do an earlier review at the 6-month mark. We initially anticipated we would be doing this review annually as is required. The team came together, we reviewed all the collated feedback, made decisions and revised the PPOs accordingly. We strive to incorporate clinician feedback and find a balance that maintains the integrity and initial purpose of these PPOs, which was to align with best palliative care practice and the BC Palliative Symptom Management Guidelines. So now explain the changes we have made. Firstly, looking at the hospital-based PPO, number 821340. In the first section of the PPOs was to include options for physicians and nurse practitioners to indicate when they want to be notified of death. Will not require a physician or nurse practitioner order. It was missed as a necessary communication piece by physicians and nurse practitioners. So we included this at the beginning of the PPO and amalgamated it with the advanced care plan in most considerations. Revision was in section 6. We changed the heading, prioritising symptom assessment as cornerstone to quality palliative care and aligning with the palliative symptom assessment clinical care standard, which requires nurses to follow with all palliative patients. We also included an option to discontinue vital sign monitoring or indicate what other monitoring is required. 7, we have changed the order of several medication classifications to condense the PPO and removed the NSAID, bisphosphonate, skeletal muscle relaxant, and bronchodilator sections. The biopyrrolate order has been changed to a PRN order. So acetaminophen is now a blank line for the prescriber to populate, allowing more appropriate dose prescribing for the selected route, depending on whether that is orally or rectally. And the of the order has been changed to simplify and clarify. Ibuprofen has been moved under acetaminophen in the analgesic section, this previously in the NSAID section. Opioid section has been condensed and simplified by removing the separate lines based on reason and replacing with checkboxes alongside the order. This allows the prescriber to identify the symptom or symptoms for which to give the opioid. This is identified on the MAR, and the nurse is also clear and should be documenting what symptom administered the PRN opioid is for when given and consequent effectiveness. In the AntiAmerican section has been edited to highlight metoclopramide as a first-line agent and drug of choice for nausea and vomiting in palliative care where it is not contraindicated, for example, bowel obstruction. The narcotic section has also been condensed and simplified by removing the separate lines based on reason and replaced with checkboxes alongside the order, similar to what was done with the opioid section. With Community Hospice Bed Long-Term Care PPO number 829571, you can see here that similar changes have been made as were made to the hospital-based PPO in regards to notification of death and symptom assessment. In the Community Hospice Bed Long-Term Care PPO, we have taken the route out for several medications, knowing that community pharmacies require a separate line for each route. Now inserted a blank for the RP to indicate what route they would like that medication to be given. For example, acetaminophen. This summarizes some additional changes made to the PPO. Reduce the length down to 2.5 pages. Prescribing guidelines and supporting resources provided on the reverse of page 1, 2, and 3 remain. For this reason, we encourage the PPOs be printed double-sided. The list of questions and requests for nurse to pronounce being added. We have not added it as it is well within nursing scope of practice to pronounce an expected death and therefore does not require an MRP order, and is documented in the Care of the Deceased Clinical Practice Standard. On the screen here we have the Acute Care Clinical Practice Standard for the Care of the Deceased. We have shown where it is documented in the Long-Term Care of the Deceased Clinical Practice Standard. Remember also that these PPOs are for the palliative population. So about how to use these orders, they are different to the fentanyl and insulin order sets, which are single drug specific, whereas the palliative PPOs support multi-symptom management for the majority and common symptoms that we see arising in palliative care. Following initial completion of the palliative symptom management PPOs, we wish that physicians and nurse practitioners use the physician order sheet for further medication titration or changes. And to remind everyone that using these palliative PPOs support best practice and is strongly encouraged and is the standard in our entire health. So to the Palliative Symptom Assessment Clinical Care Standard, assessment is cornerstone to good quality palliative care. Nurses are required to follow the Palliative Symptom Assessment Clinical Care Standard for all people who are palliative. So we encourage physicians and nurse practitioners to ask nurses about their palliative assessment, including ESAS, Symptom Assessment O to B, Palliative Performance Scale, and PRISME, as this provides comprehensive information and understanding of the symptom issues and guides management going forward. And we had Palliative SBAR, form number 855211, which can be used to communicate assessment findings and needs of patients with palliative needs to the physician and or nurse practitioner. So these palliative PPOs go live in the system on October 1st, 2020. The next steps will be to review annually and revise if and where needed. Body of work related to continuous subcutaneous infusions and CAB pumps. Our goal is to create a health authority-wide palliative continuous subcutaneous infusion PPO, which will provide further support and direction for palliative CSCI in various care settings. So when that is complete, we plan to remove the CSCI section of the palliative symptom management PPOs, condense it further. Thanks for listening, and again, just to remind everyone, these palliative PPOs will go live on October 1st. Thank you.